We will talk about atopic dermatitis. Atopy is used for a group of hereditary disorders in people who have a tendency to develop urticarial response to food and certain inhaled substances. So these people will show an allergic response when they are exposed to certain foods and inhaled substances. The definition of atopic dermatitis: it's an endogenous type of eczema. It is characterized by extremely pruritic, that is extremely itchy, recurrent, symmetric eczematous dermatosis. The site of affection depends upon the age of the patient. Also, there is personal or family history of allergic rhinitis or asthma or hay fever. So, this family history again is an important characteristic feature here. And there is increased ability to form IgE to common environmental allergens. So, these are the four criteria. Etiology: genetic autosomal dominant inheritance is seen here. Atopic diseases tend to run true to type within each family. Therefore, affected members of the family have eczema or respiratory disorders. Taking the history of the family members also is very important in atopic dermatitis. Immunological changes: there is elevated IgE levels, and most of them, 80% of the patients, have their IgE levels more than 200 international units per milliliter. And also there's increased specific IgE to multiple allergens, including certain foods or aeroallergens or microorganisms or bacterial toxins. And also there's increased IgE receptors on the B cells. So there's increased IgE, also there's increased IgE receptors as well. The abnormalities of lymphocytes are seen here. There's decreased delayed hypersensitivity reaction, and there's decreased circulating T cells and increased proportion of B cells with surface bound IgE is seen here. So antigen attaches to the IgE and mast cells, and that causes mediators release. The mediators of inflammation will be released into the tissues. Epidemiology: it is seen in 3% of all infants. It begins at 3 to 6 months of life. And increasing incidence is seen worldwide because of increased exposure to pollutants, increased indoor allergens, and also decrease in breastfeeding. All of this will cause increased propensity to develop atopic dermatitis. Clinical features: we have infantile phase, childhood phase, and adult phase. The atopic dermatitis in infancy here, it begins at 3 months of age, and there will be intensely itchy papules and vesicles which become exudative later. Initially we see papules and vesicles, and then they become exudative, and lesions here classically start on the face but can involve the whole body later. But the diaper area is classically spared here. That's important here to note. Okay, and then there can be secondary infection of these papules and vesicles, and it's a chronic course. The childhood phase, here we can see dry, leathery, extremely itchy lesions, and the elbows and knees are involved in this condition. So the site of involvement has changed here. Now coming to the adult phase, here we see very itchy lichenified plaques. That is, the skin will be thickened and there will be increased surface marking of the skin here. That is lichenified plaques we see here. And the area site of involvement would be the cubital and the popliteal fossa, sometimes on the neck also. Discoid pattern of eczema on the hands and feet can be seen. So this is an infant with the papulovesicles on the face. This is on the elbows. This is adult atopic dermatitis surrounding the lip, which mimics lick dermatitis here on the hand here. Associated features, very importantly, these are asthma, hay fever, food allergies, urticaria. All the other allergic disorders will be associated along with family history of the presence of the same. Complications, it can go into the bacterial infection, viral infection of herpes simplex, molluscum contagiosum, and human papillomavirus. Fungal infections can be seen. Disturbed sleep is seen because of intense itching. And also there is poor growth. It is said that growth hormone is produced during deep sleep. But here, as the sleep is deprived, so we see that there is growth retardation and social and psychosocial disturbances because of severe itching and the lesions. So investigations by prick test in measuring the Ig levels. Normally Ig levels will be less than 200 international units per ml, but it will be more than 200 in atopic dermatitis. We have Hannifin and Rajka's criteria, which is an important criteria to diagnose atopic dermatitis. Here we have major features and minor features. Any three of them have to be present to call atopic dermatitis. So firstly we have pruritus here. Then second is typical morphology of distribution, that is, in children and infants it should be present in the face and the extensors. In adults it should be present in flexural area with lichenification. So that's the second one. Third is the dermatitis, chronic or chronically relapsing dermatitis should be present. And then there has to be personal or a family history of atopy, either of asthma, allergic rhinitis or atopic dermatitis has to be present. So pruritus, typical morphology of the lesion, dermatitis and family history. Minor features includes cataract, cheilitis, conjunctivitis, facial pallor, food intolerance, hair dermatitis, ichthyosis, elevated levels of IgE, immediate skin reactivity, infections, itching, keratoconus, keratosis pilaris, nipple dermatitis or vital darkening, palmar hyperlinearity, that is increased palmar creases, perifollicular accentuation, pityriasis alba, white dermographism, wool intolerance, and xerosis. So all of these features, any three of them if they are present, it can be called atopic dermatitis. The differential diagnosis includes infantile seborrheic dermatitis, scabies, and airborne contact dermatitis. Then seborrheic dermatitis, less than 3 months are affected and it is asymptomatic, and seborrheic areas are involved, that is scalp and major flexures. Here it is more than 3 months, they are extremely itchy and other body parts also may be affected, and family history, personal history is present of atopy is present here. Scabies, papillovesicles can be seen, burrows can be seen characteristically, and palms, soles, genitalia, face can be involved. Family members also are affected here. Here we see papillovesicular lesions, palms and soles is paired here. Atopic diathesis in the family will be present. Airborne contact dermatitis, lichenified plaques will be present, mostly on face and flexures. Here lichenified plaques again, face is relatively spared, flexures are involved here, face is spared here, okay? And family history along with nipple eczema can be present. The treatment options include general measures like the parents of the patient have to be explained about the disease and they have to be counseled. Avoidance of triggers is very important. Any trigger that causes any allergen that can trigger the disease have to be avoided. Irritants have to be avoided, like woolen clothes and certain chemicals have to be avoided. Excessive degreasing of the skin has to be avoided, and mild lotions and cleansing lotions have to be used. House dust mite avoidance and milk and eggs, which are said to be allergens, have to be avoided. And breastfeeding is encouraged because it is said that it will decrease the inflammation and the allergic response. Topical therapy is with hydration of the skin is what is very important. So giving emollients and moisturizers to the patient is what is very important here. It causes reduction of itching and scratching, and it will also protect from the environmental allergens. There will be suppression of inflammation and prevention of secondary infection by using this emollients. Moisturizers is again to reduce itching, can be added to the bath or they can be applied immediately after bath. A lukewarm bath for 20 minutes is followed by application of an occlusive or hydrophilic emollient to retain the moisture. That's how we advise the patients to use. Immediately after a bath, within 3 minutes ideally they have to apply the moisturizers. Topical therapy with corticosteroids, they start with low potency and then increase the potency. Avoidance on genitalia, face and intertriginous areas because of the side effects. In lichenified lesions, they can be combined with keratolytic agents like salicylic acid also. Mostly in adults we see lichenified lesions and they can be combined with salicylic acid. Topical immunomodulators can be given like tacrolimus, pimecrolimus. They are steroid-sparing agents. They don't have the local side effects that the steroids have, and they cause rapid reduction in itching. These are the advantages of using topical immunomodulators. Systemic therapy with systemic antibiotics. If there is any secondary infection, then you can use the systemic antibiotics. And systemic steroids also can be used if the disease is not coming down with the topical agents. And antihistaminics, mostly the sedating type of antihistaminics to reduce the itching and improve the sleep quality. We can give sedative antihistaminics as well. Neotherapies with NBUB and PUA therapy, oral primrose oil for 3 months also has been used, and cyclosporin also have been tried.